Good afternoon, everyone. Assalamu alaikum wa rahmatullah. As DC and Debbie introduced me, my name is Mahal Joaid. I am the Director of Nursing in Hemodialysis, King Abdulaziz Medical City. It's my pleasure to share this session with DC and Debbie this afternoon. I hope you guys are going to learn and enjoy the dialysis symposium. I wish you all a pleasant Nurses Week, as well as a happy Nurses Day. We celebrated Nurses Day yesterday, and I think nurses should celebrate their great contribution to patient lives every day. And I hope, inshallah, God will reward you all with your outstanding effort to serve patient population across. Thank you so much.
Thank you, Ms. Maha. Okay, without much further ado, we'll move to the first presenter for this afternoon. And it gives me great pleasure to present Mr. Jawad. He is the Vascular Access Coordinator in North Center. He has 17 years experience and 8 years as a Vascular Access Coordinator. His talk today will be about aneurysm management in hemodialysis. Mr. Jawad, you can start your presentation. Thank you so much.
Thank you, Ms. Bibi. Thank you, Ms. Maha. Can you hear me?
Yes, we do.
Okay. Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. I am Jawad Al-Hamouri, the Vascular Access Coordinator in Riyadh North Dialysis Center. First, I would like to thank the organizing committee for inviting me. And I want to thank my direct nurse manager, Ms. June and Ms. Debra, for the chance they give me to participate in this symposium. Also, I would like to send my regards to all nurses worldwide in our Nurses Day held yesterday. On behalf of Riyadh North Vascular Access Team, I'm going to present about the management of one common hemodialysis access complications, which is aneurysm. With this presentation, I'm going to discuss and explain the following objectives. Introduction of the value of AV access, definition of aneurysm and pseudoaneurysm, classification or difference of true aneurysm and pseudoaneurysm, prevalence of aneurysm, etiology of aneurysm, sign and symptoms of stable and unstable aneurysm, monitoring of aneurysm, nursing management of aneurysm. We'll try to talk in details about nursing management of aneurysm. And lastly, we'll talk about the surgical option of aneurysm management. What's the value of AV access? According to National Kidney Foundation, with their recommendation and guidelines, they consider that AV fistulas is the gold standard providing access for hemodialysis patients. As a result of that, AV access had superior patency, fewer complications, require fewer re-interventions, lower morbidity, greater cost effectiveness, and ultimately improve patient survival. So the access considered as a lifeline for a lifetime. Definition. Aneurysm and pseudoaneurysm has no uniform definition. Several authors have defined aneurysm in different ways. Jankovic developed a score based on the sum of the length and width in the centimeters for the aneurysm fistula. Baskinsky and colleagues used a definition of dilatation to more than 3 times the native vessel's diameter, with the minimum being size 2 centimeters. Rajput also used relative size to the adjacent AV fistula and defined aneurysm as a focal dilatation of the outflow vein diameters greater than 2 times the normal caliber of the adjacent normal fistula vein segment. As we can see in picture A, aneurysm taken by Doppler machine. Pseudoaneurysm or false aneurysm is a vascular abnormality that resembles an aneurysm, but the outpouching is not limited by a true vessel walls, rather by external fibrous tissue, as we can see in image B here. The pseudoaneurysm, it's not connected, it's not dilatation of the true vessels, it's outside the true fistula vein. Stenosis, it's also always come with aneurysm. It's a constriction or narrowing of a duct or passage blood vessels. This narrowing is usually the result of build up the plaque within the blood vessels. You can see in this picture, see here, there is 2 narrowing sites with this fistula. Another way to describe the aneurysm is the outside skin shape of the fistula vein. As Mr. Valenti proposed classification system based on fistula morphology, recognizing 3 types of aneurysm. Types 1 to 3 being true aneurysm and type 4 being pseudoaneurysms. As we can see in this table, type 1A, the vein is dilated almost uniformly from the arterial anastomosis along most, if not all its length. The appearance resembles a hose pipe. In type 1B, the proximal part of the vein is dilated. This is almost entirely seen within 5 cm of the arterial anastomosis. In type 2, there's at least one localized dilatation of the vein, but more often 2. This is classic camel hump. This dilatation appears to correlate with site of needle for dialysis. In between this localized aneurysm, the vein returns to the normal caliber, or it is in some cases stenosed. In type B here, we can both anastomotic aneurysm and also localized dilatation. This is effectively a combination of type 1B and type 2A. Combination between this type and this type, we can see it in type 2B. For type 3 aneurysm, this is represented a fistula aneurysm which did not fit the group above and bore no resemblance to each other. So it's irregular in the shape and in the criteria. For type 4, as we see here, this may appear as a true localized aneurysm, but on duplex testing will be shown to be a false aneurysm. An intraoperative specimen is shown here, the pseudoaneurysms. Different type of aneurysm I want to highlight it due to the common specific factors that leading to form this type of aneurysm. This type is called mycotic aneurysm. As we see in these attached articles that published in Saudi Journal of Kidney Disease and Transplantation in 2015. This aneurysm occurred when there is a combination of the axis thrombosis and axis infection, which according to the histology result leading to weakening the vessel's wall resulted in damage of the integral structure of the fistula and the formation of rapid dilatation. Interesting to this type of aneurysm is the rapidly dilating of the aneurysm that could be happened within a weeks and became unstable aneurysm, as we can see in these pictures. What's the prevalence or the incidence of the aneurysm? Compared to all other complications, literature data about vascular access aneurysm are the rarest. Also, I attach another article here, which is published in October 2013. It shows that 60% of research sample patients had aneurysm. And according to these articles, they found that vascular access aneurysm were more frequent in patients with adult polycystic kidney disease than other diagnostic categories, and in those patients who had longer dialysis vintage on high flux membrane with higher blood flow rate. More etiology we'll discuss in the next slides. What's the etiology of aneurysm? The etiology of aneurysm or pseudoaneurysm in the AV fistula is less clear. Several authors have attempted to identify other factors which may put the patient in high risk to develop aneurysm. Repeated needling results in multiple same fibrous scars in the vessel wall, which may expand with the time and result in localized aneurysmal area. In area where needling has not been performed, aneurysmal dilation can occur, and the high flow through the vessels may result in abnormal shear stress, which promote outward remodeling and gradual dilation with grossly increased caliber of the vessels. Stenosis, which exacerbate abnormal hemodynamics, may be associated with aneurysm formation. The nature of the vessel's wall may be implicated, and some patients may have predisposition to aneurysm formation. This is seen in other aneurysms with connective tissue disorders, and higher aneurysm formation in vascular access has been described in Albert syndrome. Other disease states are associated with aneurysm elsewhere. For example, adult polycystic kidney disease, as the articles mentioned, which is associated with intracerebral aneurysm, have been shown to increase the diameter of AV fistulas. Repeated localized puncture prosthetic graft result in pseudoaneurysm, although true aneurysm can occur in the arterial inflow. Let's move to the signs and symptoms of aneurysm, starting with stable aneurysm, as we can see in this picture. Unchanged in size over time or within short time. Thick wall, vein, thick intact skin, not shiny or thin. Nose caps larger than needle site. Normal thrill and probe. No necrosed area. As this example of stable aneurysm. Going to unstable aneurysm, as we can see in this picture. Thin, shiny, and atrophic overlying skin, with or without ulceration. Limited suitable segment for cannulation, it could be. Rapid increase in aneurysmal size. Evidence of infection. intra-aneurysmal thrombus formation and developing stenosis, like this area. Evidence of spontaneous bleeding or life-threatening hemorrhage. So how to monitor the aneurysms? Actually, there is no uniform way how to monitor and measure the aneurysm, but some of the dialysis unit made a unit-specific guidelines to direct their nursing staff how to monitor, assess, and what is the recommended action should be taken to this kind of situation. With this table is an example of recommended aneurysm monitoring and scoring. We can see how they categorize the signs and symptoms of the findings, and they give each sign and symptoms scores with color coded for each category and what is the recommended action. Another and simple guideline about aneurysm stages and what is the recommended action. We can see almost all the guidelines highlighted the condition of the skin over the fistula or over the cannulation area as a references. We can see stage 0 fistula with normal size and skins, no action required. For stage 2 enlarged fistula with normal skins, we have to monitor. In stage 4 enlarged fistula with shiny skin, refer to vascular access team or also physician as well. Stage 4 enlarged fistula with open ulcer. It needs urgent referral or intervention. As their latest 2019 KDOQI guideline also, they talk about how to monitor the aneurysm for vascular access. They identify the physical examination findings that are clinically relevant to differentiate between aneurysm, pseudoaneurysm that do not require urgent intervention and those of urgent concern. They focus in their physical examination findings about the size of the aneurysm. Is it enlarging or not enlarging? Overlying skin can be benched easily or not. Thin, shiny, depigmented. For skin erosions, none, or if there is ulcer scapes, it will be like an urgent or attention, rapid attention. For arm elevation sign or test, collapse, anormal or may not collapse, that means there is a stenosis. In case there is bleeding from the puncture site during or after dialysis, if it's uncommon or if it's recurrent or prolonged bleeding. So in this slide, we are going to talk about how to measure the aneurysm. There are many ways to measure the progression of the aneurysm. Actually, there is no standard way to follow. Each unit has its own policy and procedure regarding aneurysm measurement and monitoring. In picture A, we can see how they measure the circumference of the skin around the aneurysm site.
Jawad, we've lost sound.
Is it fine now?
Yes.
So let's talk now in details about what's nursing management of aneurysm. As we know, the assessment is the first steps of everything. Perform proper access assessment before every hemodialysis session. Compare your findings with previous findings. Use the cheapest and easiest technique. Look, listen, feel your patient access every treatment. Assess transverse and longitudinal measurements. Flow and thrombus and wall characteristics. Feel the intravascular pressure along the vein. Examine the segmental differences, as we can see. Recognize the difference between stable and unstable aneurysm with each criteria for each type. Note for skin integrity. Avoid cannulating the axis segment that involve the aneurysm or pseudoaneurysm if they are alternative site. As we can see in this picture, we try to find alternative site for cannulation. If not suitable alternative cannulation site, the side or base of the aneurysm or pseudoaneurysm should be cannulated. Avoid the top of aneurysm or the skin, as we can see in this picture. So we have to go for adequate soft tissue. Follow the appropriate cannulation technique. As we know, we have many of cannulation technique: bladder, area cannulation, and buttonhole technique. Actually, each cannulation technique has a specific criteria to use. It's not applicable for all patients according to the patient axis and condition. But we have to try to priority to give it for rope ladder technique. Rope ladder technique, the cannulator rotates the needle placement site for each dialysis, choosing sites at a defined distance along a line from the previous puncture site, which is the best. Area cannulation refers to puncturing of the same general area, session after session, but the repeated needle puncture in the same area weakens vessel's wall and predispose the axis to the development of aneurysm and axis stenosis. Buttonhole, this is the method in which an individual cannulate the AV fistula in the exact spot at the same angle and the depth of penetration every time. A scar tissue tunnel tract develops, allow the use of buttonhole or the blunt fistula needle. Talking about cannulation technique actually pushed me to share our project in Riyadh North Dialysis Center to enhance our staff nursing cannulation skills and to minimize access complication for our patients. I will talk about this project briefly. Vascular access team categorized patient accesses to easy, moderately complicated, and complicated accesses. Then we set specific cannulation practical criteria to be achieved by staff nurse to be either competent, skilled, and advanced cannulators according to their skills and performance. So, competent staff nurse will deal only with easy access. Skilled staff nurse will deal with moderately complicated access and easy access. And the advanced staff nurse will deal with all categories with Doppler ultrasound training provided. As we see, this is the acknowledgement of the first group of cannulators last February 2020. Continue with nursing management. If Doppler ultrasound machine is available, obtain appropriate imaging of the arterial inflow and venous outflow to assess volume flow and or stenotic problems that may need correction prior to or during definitive treatment of symptomatic aneurysm or pseudoaneurysm.
So about 5 minutes left.
Okay. Use smaller needle gauge for cannulation. If applicable, consider patient built and prescribe blood flow rate. Do not apply the tourniquet tightly or do cannulation without using the tourniquet for those patients with aneurysms. Avoid cannulation the previous healing cannulation site. Always find a new site like this brightness or different color skin area. Avoid total insertion of the needle hub. We called it hubbing, as we see in this picture. It's increased the puncture site of the needles and make it big hole of penetration. Ensure tapes are placed correctly, preventing needle dislodgement. Keep proper endorsement and documentation regarding to your findings. Inform staff physician, in which cases vascular referral may be made, obtaining fistulogram. Refer to vascular access coordinator or nurse for further monitoring and management. Surgical management is the preferred treatment for patients with symptomatic, large, rapidly expanded AV axis aneurysm or pseudoaneurysm. As we can see, treating axis in these pictures. In this slide, I add some examples of surgical management of aneurysm. We can see ulcerated fistula aneurysm successfully treated with surgery in picture A and B, corrected by replacement with interposition graft. This is before treatment and 6 weeks after treatment. As well, the second case before treatment and after treatments. Another example of surgical management with ruptured fistula with aneurysm that could be life-threatening situation. So each healthcare team member are responsible to prevent this kind of complication. One of the important part of aneurysm management is patient education. So please educate the patient about the importance of rotating cannulation site every dialysis session. Teach patient how to assess vascular access presenting with aneurysm or pseudoaneurysm. Educate the patient about signs and symptoms of aneurysm or pseudoaneurysm and the need to inform the nurses and the physicians about significant changes and why. Educate patient on what to do if rupture the aneurysm or pseudoaneurysm occurs at home. Educate the patient to comply with his or her vascular access follow-up appointments. Regular screen of the access, even no issue, is preferred. After this presentation, I would like to recommend the following points. Nursing staff providing direct care must be able to correctly identify determine clinical presentation of true or pseudoaneurysm in dialysis AV axis. Nurses must be aware of how to prevent progressive enlargement of aneurysm on AV axis. Aneurysm can occur if needles are inserted too often into the same area of the AV axis. Nurses must rotate cannulation site every dialysis session and must avoid cannulating aneurysmal dilatation, shiny overlying skin, with or without ulceration. Nursing staff must report abnormal signs and symptoms of aneurysm or pseudoaneurysm diligently to staff physician so patient can be assessed or be referred to vascular surgeon for further surveillance and management, preventing life-threatening complication.
1 minute left.
Okay, I'm almost finished. Let's recap our presentation. Aneurysm should be monitored by physical examination at the time of each dialysis treatment to avoid cannulating access segment that involve aneurysm or pseudoaneurysm if there is alternative site. Prompt referral for further investigation and intervention for large aneurysm can prevent possible rupture and hemorrhage, severe bleeding that can be fatal for the patient. Surgical management is the preferred treatment for the patient with symptomatic large, rapidly expanded AV axis, so aneurysm or pseudoaneurysm. My take-home message is happiness is a lifelong, well-functioning AV axis. Nursing present to lead the care. This is my references. Actually, it's more than this 2 slide references. And this is the end of my presentation. I'm happy if you have any question.
Thank you so much, Jawad. Unfortunately, we are now 1 minute over the time. We can see if there is any time left later on after the last presenter. And maybe, yes, you can then answer the questions. Thank you for a very informative presentation about the aneurysm.